Hello everyone. My name is Abdurrahman Mohammed. I am a mentee member of USMIRC. Today I will discuss precision oncology and targeted therapy. I appreciate Dr. Anwar for this opportunity and hope you find it informative. Firstly, let's explore how we traditionally fighting cancer. Historically, chemotherapy, radiation, and surgery have been our main ways to fighting cancer. Chemotherapy and radiation are non-specific and they can affect cancerous and normal cells. So this non-specificity carry a lot of side effects like hearing loss, nausea, fatigue, and so on. For surgery, while it is targeted, but also it can affect the healthy tissue due to invasive nature of the surgery. This systemic approach highlighting that we need a personalized and targeted therapy for cancer. Targeted cancer therapy is a treatment that specifically targets cancer cells by interfering with specific molecules involved in tumor growth and progression. It acts on molecular targets such as protein or genetic mutation critically for cancer survival and growth. We have two types of the targeted cancer therapy. Small molecules which can invade the cell and act inside the cell, monoclonal antibodies which act with a certain receptor. The goal of the targeted cancer therapy based on the genetic mutation. There is a genetic mutation which we act on, and there is a biomarker or any specific character for this tumor, like a protein or something like that. The aim of the targeted therapy is to optimize treatment efficacy. We make the efficacy more high and also minimize the toxicity. According to this definition and goals of the targeted therapy, we find that the traditional therapies such as chemotherapy and radiation is non-specific and attack rapidly dividing cell, both cancerous and normal. This low specificity often leads to significant side effects like hair loss, nausea, and fatigue. In contrast, targeted cancer therapy is more specific, aiming at molecules and cellular changes unique to cancer cells. This higher specificity helps spare most normal cells and fewer side effects. The resistance to therapy is another key difference between targeted and traditional. The traditional resistance is higher with targeted therapy. The resistance is persist, but it's not as high as the traditional one. Also, combining between two agent or three agent is usual in the traditional cancer therapy, but in targeted we also use the combination to decrease the side effect and also to decrease the resistance the cancer developed to the drug. In terms of treatment duration, traditional therapy often require a longer period, whereas targeted therapy can be shorter. Both types of therapies are used in combination or alone, depending on the specific case. The traditional cancer therapy has long history of use, making its side effect and outcome well documented. However, targeted therapy is relatively new, and while it holds promise, it's still under extensive research and we need a lot of research to fully understand these agents. Key principles of targeted therapy. Targeted therapy is targeting a specific molecule in the tumor, which support the cell proliferation and survival. So by targeting this molecule, this lead to death of the cancerous cell. It's also personalized. It's not depending on the histology or the pathology of the tumor, but it vary from one to one according to the mutation itself inside the cancerous cell. So maybe you have squamous cell carcinoma in two persons, but the targeted therapy will differ from this one to this one according to the mutation in each tumor. Also, the targeted therapy improves the efficacy. We have higher efficacy with the targeted therapy and low toxicity compared to the chemotherapy or traditional therapy, radiation or chemotherapy. There is a continuous development in this field in the targeted therapy, so it's a promising and they give a hope for all people having cancer. What is biomarkers? Biomarkers are biological molecules found in blood and other body fluids or tissue that is a sign of a normal or abnormal process or a condition or a disease within the body. We use biomarkers for diagnosis, monitoring, and we use them as a specific target for the targeted therapy. For diagnosis, we have the BSA, prostate-specific antigen for diagnosis and monitoring the prostate cancer. We have the CA125 for monitoring the ovarian cancer, and so on. Here is a list for some biomarkers we found in cancer and non-cancerous disease. For cancerous, we have the EGFR here, which is a tyrosine kinase involved or have a function in the cell growth, and it's found in the non-small cell lung cancer. We have also KRAS, which GT-base involved in cell signaling, and also it found in non-small cell lung cancer. For non-oncology, we have here the HLA-B27, which include a protein involved in an immune response, and we find this in the ankylosing spondylitis. In this picture, we see that biomarkers are applied in many of disease in medicine, but it's mainly used on oncology. Types of molecular targets. In this slide, we looking at the various types of molecular targets used in cancer therapy. These represent different approaches to attacking cancer at the molecular level. First, we have signal transduction inhibitors. These target the communication pathways within cancer cells, disturbing their ability to grow and divide. Next are hormone-based therapies, which are particularly effective against cancer that depend on hormones to grow. We find this in like prostate and breast cancers. The third is anti-angiogenic therapies. It's focusing on the cutting off the blood supply to tumor, essentially starving them from nutrition and oxygen. Moving to the delivery methods, how we deliver the targeted therapy from blood to the cell, to the cancerous cell. We have passive targeting delivery therapeutics. These include organic nanocarriers like liposomes and nanoparticles, which can carry drugs directly to tumor site. We also see nanocarriers for gene therapy and smart delivery system. These are cutting-edge technologies that allow for precise delivery of genetic materials or drugs that respond to specific condition in the tumor environment. Finally, we have active targeting delivery therapeutics. Unlike passive targeting, these systems actively seek out cancer cells, potentially improving the efficacy and reducing side effects of treatment. Each of these approaches represent a different way of targeting cancer at the molecular level, showcasing the diversity of modern cancer therapy. For signal transduction inhibitors, signal transduction links receptor activation by ligands to cellular response, playing a crucial role in molecular targeted cancer therapies. Cancer cells often have hyperactive signaling pathways due to genetic mutation or changes, leading to uncontrolled functions like proliferation. So it have unorganized proliferation. So in this picture, we found that here is the receptor. The receptor is active as a signal. This signal is go to the nucleus and make the proliferation or the action within the cell. A key example of signal transduction inhibitors is tyrosine kinase inhibitors, or TKIs. Tyrosine kinases are enzymes that play a crucial role in many cells' function, including cell signaling, growth, and division. In some cancers, these enzymes become overactive, leading to uncontrolled cell growth. TKIs work by blocking these overactive enzymes. They essentially act as an off switch for signaling pathways that drive cancer growth. By doing so, TKIs can slow or stop the spread or growth of the cancer cells. An example for the TKIs or tyrosine kinase inhibitor is the classic example is imatinib. Imatinib is a highly successful in treating chronic myeloid leukemia. Its target is the BCR EBL fusion protein, which forming a result of Philadelphia chromosome translocation. It's also used for gastrointestinal stromal tumors with a mutation in CKIT, CKIT, or BDGFR alpha. Unfortunately, the tyrosine kinase inhibitor develop some resistance. So there is a next generation of the tyrosine kinase inhibitor. We have long-term imatinib use can lead to resistance. So we have a next generation called dasatinib and nilotinib. It's are effective against imatinib-resistant chronic myeloid leukemia. We have also bosutinib. Bosutinib is approved for patients with resistance to imatinib and other TKIs, offering superior molecular response and selectivity. We have also sunitinib. Sunitinib is for imatinib-resistant gastrointestinal stromal tumors, which targets the VEGFR and the BDGFR kinases. The next one in the signal transduction inhibitors is epidermal growth factor receptor inhibitors, EGFR inhibitors. We have two key role drugs here, gefitinib and erlotinib. They both are used for non-small cell lung cancer carcinoma with a specific EGFR mutation. So the genetic screening and profiling for each patient is so important because it's not effective. It's effective only if the patient has this mutation. The third is HER2 targeted therapy. We focus. Number two in the targeted therapy is the hormone-based therapies. We said before that these type of therapy are for specific types of cancer which depend on hormones for its growth. So it's effective against tumors like breast, ovarian, and prostate cancer. But these cancer should be depending on hormones on their growth. So for examples, we will take example for breast cancer. So the estrogen and breast cancer are linked. So we have estrogen receptor, and the estrogen receptor is a nuclear receptor. We have two types of the estrogen receptor alpha and estrogen receptor beta. The estrogen receptor alpha is overexpressed on breast cancer, and the overexpression is linked to hormone-dependent tumor growth. So if there is overexpression of the estrogen receptor alpha, there is it's linked to hormone-dependent tumor growth. The prevalence of this thing is about 70% of breast cancer are hormone receptor positive, estrogen receptor positive. So we have 70% of the breast cancer positive for estrogen receptors. So 70% of the breast cancer will affected by targeted hormone-based targeted therapy. So the hormone therapy will reduce estrogen growth stimulating effect on breast cancer cells by interfering with estrogen binding to receptors. This is the first way. And the second way, decreasing the estrogen level. So the hormone therapy will work on two ways. First, interfering with the binding site of the receptor. So the normal estrogen can't acting on the receptor. The second is decreasing the level of the estrogen level. For the types of the estrogens dependent therapy. We have the selective estrogen receptor modulator. The example of this category is tamoxifen. Tamoxifen is used in pre and post-menopausal women and men with estrogen receptor positive breast cancer. The limitation of this drug is the potential increased risk for endometrial cancer. So it's effective, but has a serious side effect. And here goes the second category. The second category here is the selective estrogen receptor down regulator, which is like if flavistrant, which its advantage is has no increase in the endometrial cancer risk. The third category is aromatase inhibitor like exemestane, which is approved for postmenopausal women with hormone receptor positive breast cancer. So the end result or the conclusion of this example is the treatment choice. The targeted therapy depends on the cancer stage and the menopausal status and the previous therapies. So profiling for each person, profiling for each person is so important in the targeted cancer therapy. Number 3, anti-angiogenic therapies. First, what is angiogenesis? Angiogenesis is the process of forming new blood vessels from existing one. In normal pathology, this is crucial for wound healing and tissue growth. However, in cancer, this process becomes prolonged and directly supporting tumor growth. The blood vessels that form within tumor have distinctive characteristics that set them apart from normal vasculature. They are defective, highly heterogeneous in structure, and extremely permeable. This abnormal structure leads to increased interstitial fluid pressure within the tumor. These characteristics of tumor vasculature have significant implication for cancer progression and treatment. On one hand, they promote tumor growth by providing steady supply of nutrients and oxygen. They also facilitate metastasis by offering cancer cells easy access to the bloodstream, allowing them to spread the mets around all over the body. On the other hand, the abnormal nature of tumor blood vessels can defeat our efforts to treat cancer. They increase the interstitial pressure, and irregular blood flow can prevent the chemotherapy drugs from effectively penetrating the tumor. This creates a paradoxical situation where the very blood vessels supporting the tumor's growth also protect it from treatment. Understanding this aspect of tumor angiogenesis has led to the development of anti-angiogenic therapies, which aim to stave the tumor from cutting off its blood supply. It has also driven research into ways to normalize the tumor vasculature to improve the delivery of chemotherapy drugs. So, for anti-angiogenic therapy or drugs, we have VEGF inhibitors like bevacizumab, which is a humanized monoclonal anti-VEGF-A antibody, binds and neutralizes circulating VEGF-A and leads to vasculature normalization, which approved for various cancers like RCC, renal cell carcinoma, and CRC, colorectal carcinoma. This aflibercept is a recombinant fusion protein. It's a VEGF domain with IgG FC portion, which traps VEGF A, VEGF B, and B1GF, which is approved for metastasis of CRC, colorectal carcinoma. We have some factors we have to focus on during using the anti-angiogenic therapy. The first is the cancer type, and if it is angiogenesis dependence or not, because there are some drugs, some cancers are express the VEGF and has a lot of angiogenesis, but it's not depending on angiogenesis, so the treatment will be not effective. The type of anti-angiogenic agent you can use, and the combination with chemotherapy, because the aiming of anti-angiogenic therapy is to deliver the chemotherapy to the tumor, to normalize the vasculature to deliver the chemotherapy for the tumor. And the timing and sequencing of administration, this is also so important, and the personalization approach, as we said, the profiling for each patient is so important for optimal efficacy. This slide is a list for the drugs we mentioned, with each drug with its target. For here we have the tyrosine kinase inhibitor, the monoclonal antibody trastuzumab, which targets the HER2, hormonal therapy, tamoxifen, which targets the estrogen receptor, and etc. Small molecules designed to transport drugs directly to cancer cells. Their properties are crucial for their effectiveness. First, let's consider the size. The optimal size range from nanocarriers, typically from 10 to 100 nanometer. The size allowed them to navigate through the bloodstream, penetrate tumors tissue effectively. The surface charge, another critical factor. Neutral or slightly ionic nanocarriers can evade the renal elimination, prolonging their circulation time. On the other hand, cationic or positively charged nanocarriers can enhance cellular uptake, improving drug delivery into the cancer cells. Surface modification technique, such as surface modification technique in general, give nanocarriers some properties. This increases the circulation time and reduce the clearance by phagocytosis in the endoplasmic in the reticuloendothelial system, allowing more drug to reach the cancer. Now let's talk about the type of nanocarriers. We have organic nanocarriers like liposomes, and inorganic like carbon nanotubes, and hybrids, which are a combination of both from both of these types. Here is the liposomes nanocarriers. Liposomes are, as a drug delivery systems, has microscopic bilipid layer, spherical vesicle with aqueous core, composed of neutral synthetic lipids like phospholipid and cholesterol, can enter cells by endocytosis, capable for encapsulating both water and lipid drugs. For in this picture, this is hydrophobic molecules, and this is the hydrophilic molecules. Can be coated with polymers or sheath properties, and also all of these helps to penetrating and delivering the drug to the targeted cells. The example for the liposomes nanocarriers is the Doxil. Doxil is the only FDA-approved liposomal cytotoxic agent for solid tumors. It's used in ovarian cancer and multiple myeloma. It has a lot of advantage over the conventional doxorubicin because it is a reformulated version of the doxorubicin. First, it's improved the safety profile, reduce the cardiotoxicity, different toxicity profile according to the dose, and less of the adverse effect. Second, enhancing the pharmacokinetics because it is more stable in the systemic circulation, has a longer half-life and slower clearance rate, and also improved the tumor targeting because the extravasation into leaky intra-illuminal vasculature because its properties of the liposomal or the bilipid coat, and it is better therapeutic efficacy because it's improved the therapeutic index compared to the doxorubicin. Second, we have nanoparticles as drug delivery systems. We have abraxane, which is an FDA-approved polymeric nanoparticle. It's composed of paclitaxel bound to albumin. Size is around 130 nanometers. Particles indication is metastatic breast cancer and non-small cell lung cancer. Okay. The advantage over the traditional paclitaxel is it is solvent-free formulation, reduce the hypersensitivity reaction, enhance the tumor accumulation, improve the endothelial cellular uptake, higher maximize tolerated dose, and less severe and frequent adverse effect. The key points of nanoparticles formulation, it's overcome solubility issues of hydrophobic drugs, can compete this, and enhance the drug stability and the bioavailability, better bioavailability, and improve tumor targeting and cellular uptake, reduce the adverse effect associated with the traditional formulation. Nanocarriers for gene therapy and smart delivery system. In the gene therapy in cancer, it's aimed to replace the knocked out mutations or inserted new genes. It targets endogenous tumor gene expression, potentially for high potency and specificity challenges. And specificity challenges is the toxicity and instability of the next genetic materials. Also, I don't know. Also, the old drugs in this category still under experiment. But we have here on Batro. It's approved in 2018. This is the first FDA approved RNA interference therapeutics. It uses lipid nanoparticle to deliver RNA, siRNA, small interfering RNA to treat hereditary trans-13 mediated amyloidosis. So in this last slide, let me summarize how the targeted therapy works. First is identify. We find a special markers. We first find a special markers on the cancer cells. It's like spotting a unique tag on each cancer type, then design. Thank you for listening, and I hope you find this useful. Goodbye.